Hello, everyone. My name is Brendan Hayes, and I'm the Director of Education for Innovative Therapies with NHF, and we're so excited to have you here tonight. First off, I'd like to thank our sponsors, Takeda, BPL, CSL Behring, and Novo Nordisk. Wanted to just do a little housekeeping. First off, we want to talk a little bit about the naming policy. So those of you, if you could name, that are consumers, if you could change your name, and you do that by hovering over your picture, and there'll be 3 little dots. If you click on that little icon, it'll give you an option to rename. And if you could put your first name, comma, your country, and then we have information for our other attendees as well. Wanted to make sure everyone understands that this session is being recorded. It's for internal purposes only. We want to ensure that we're providing the best programming for our community. And of course, it's up to you all if you are interested in having your camera on or not. We'd love to see your beautiful faces, but of course, it's up to you to have those on. So in terms of getting the most from this session, wanted to let you know that we do have a chat box, and we have a fabulous chat manager tonight, John Velasco. And so if you could use that chat box to ask any questions, John will be monitoring those. We're going to hold questions until the very end so that both of our speakers can get through their content. If you'd like to ask a question anonymously, feel free to text or I should say chat directly with John. And at the very end of the session, there is an opportunity, or I should say tomorrow, there'll be an opportunity for you to do a survey. So we're very interested in your feedback on the session. So with that, let me go ahead and introduce our 2 speakers. So Dr. Suchitra Acharya, and she is from the Cohen Children's Medical Center in New York, and Dr. Danielle Nance, who's with Banner MD Anderson in Arizona. Welcome, ladies. We're so happy to have you and looking forward to this great presentation.
Hi, thanks for having us, and I'm really excited to be here today. I think Dr. Suchitra Acharya is going to go ahead and bring the slides up. And then we can get started with the talk.
Yes. Hi, everyone. I'm very excited to be here today with my co-speaker, Dr. Danielle Nance. I'm going to share these slides with you in just a minute. And there we go. So Danielle, you want to go get started? These are our disclosures, none of which from my end is relevant to today's presentation.
Okay. And same for me. So we know with this conference that most of us are starting out a little bit reminding the group about hemostasis. And so I am going to spend 1 or 2 minutes with my version of the story. We spend almost all of our time figuring out how this applies to bleeding and clotting in our patients. So just reminding everyone that, the hundreds of thousands of miles of blood vessels in a person with a bleeding disorder, any of these vessels can bleed. Unfortunately, most of the time they don't, but, with a rare bleeding disorder, we can see bleeding really, from anywhere. So we want to encourage you, if you have any symptoms and you're not sure what they are, to please reach out to your hematologist and tell them what's happening to you. So if it is a bleed, we can figure out what to do to make that better for you. Great. Okay. So when we're talking about bleeding, the healthy blood vessel really protects the blood from going, from a liquid and turning into a gel. And it's almost always only after the blood vessel has been injured or torn that the clotting process happens. And the first thing that happens is really that that blood vessel will spasm down and clamp down. And when it does that, it releases some clotting proteins out of the surface. And also, you know, the wound itself exposes collagen. And I've drawn in that yellow line to represent the collagen. And collagen is super, super sticky to the stuff that's in the bloodstream. Once the blood vessel has been injured and the sticky clotting proteins are starting to activate, the first thing that happens is the platelets will stick to von Willebrand factor and pile up. And then the second part of that is where the activated clotting factors get pulled down onto the surface of the platelets, and they build what we call a fibrin net, and that is called secondary hemostasis. And then finally, the blood clot itself gets remodeled by some of the natural anticoagulants, and some bleeding disorders can actually happen if that process is too robust. So if the natural anticoagulants tear that clot down before it's secure, and which is what happens in factor 13 deficiency, then then you get a bleeding problem again as well. So it's sometimes it's not just about the absolute amount of each clotting protein, but it's also about the balance between the pro-clotting factors and the natural anticoagulants, so that that clot doesn't get broken down too soon and that clot doesn't get too big. And finally, the purpose of the clotting system altogether is to restore blood flow and to allow healing of that injured tissue. Okay, you can go on. This is just a little bit of a closer up surface, looking at how the blood vessels and the von Willebrand factor and the collagen and the platelets are all interacting together. And the picture up here in the left-hand corner of your screen is the platelet plug, is a healthy platelet before it's been activated. And then the platelets are going to connect to the collagen and the von Willebrand factor. And when they do that, they become activated and they basically explode themselves open. And you can see that the picture in the lower right-hand corner here, it looks like a lot more sticky, like it can cover up some of those wounds and to help stick to the wound bed and to other platelets to help build that platelet plug. And this is just another close-up view of how the clotting proteins are actually being pulled down into the surface of those platelets. And then this is showing, so you can use your imagination here to see that clotting doesn't happen in the bloodstream. Clotting actually happens on the surface of those platelets. And so once you get that platelet plug nice and secure, then the dissolved clotting proteins help to build the fibrin net across the platelets. And they don't do it inside the bloodstream. It has to be done on a surface. So those, so a lot of times with the rare disorders and the rare platelet disorders, getting those platelets to stick in the first place and then having the coagulation factors being around and having enough of them in the bloodstream are very important in order to being able to build that fibrin net. Next slide, please.
Okay, thank you, Dr. Nance, for that wonderful overview of the clotting process and the healing. So when we talk about rare bleeding disorders, they comprise about 3 to 5% of inherited bleeding disorders after the more common ones, such as von Willebrand's disease and hemophilias. And amongst the rare bleeding disorders, factor 7 tends to be the most common, as seen in this pie chart, followed by factor 11, which are the two most common of the rare bleeding disorders. And then the rarest of them is factor 2 deficiency and combined factor 5 and 8 deficiencies. And our knowledge about rare bleeding disorders has vastly improved because of registries that have been maintained in the UK, Italy, and Iran. And what we've observed from data from these registries is that if you look at the lower box, which describes the prevalence of factor 8 and 9 deficiencies, which are the hemophilia A and B, they are similar in the all the three registries. But if you look at factor 7 deficiency, which I'm using as an example, since it's the most common, you will notice that the prevalence of factor 7 deficiency in the Iranian registry is 3 to 5-fold higher than that reported in the Italian and UK registries. And why do we think that happens? And the reason that is actually brought forth is because of a high rate of consanguinity in countries like Iran and other Middle Eastern countries and in countries in Southeast Asia, where the rate of consanguinity can range anywhere from 40 to 85%, as you can see in this slide, which translates into a 3 to 7-fold higher prevalence of these disorders as compared in these countries as compared to developed countries. The World Federation of Hemophilia did a survey and reported equal distribution of these rare bleeding disorders in males and females, males represented by red and females by blue. And the reason for this is rare bleeding disorders are autosomal recessive in inheritance, and it can the disease can occur both in males as well as females. Unlike the hemophilias, in the top bars you can see, which is all red, is predominantly in males because of the X-linked recessive inheritance. Now, given the rarity of these rare bleeding disorders, there are certain issues that arise both at the provider end as well as the individual and families. The biggest problem and challenge about rare bleeding disorders is the low numbers that we see at most of the treatment centers, which leads to a delayed recognition of these bleeding disorders despite presenting with significant bleeding symptoms. Also, the bleeding symptoms are not uniform. They are very heterogeneous. And a lot of times factor levels do not correlate with the bleeding symptoms. And that really poses a big challenge in making the diagnosis. And once you don't have an accurate diagnosis, it's very difficult to formulate an effective treatment plan to prevent bleeds. For individuals affected by rare bleeding disorders, it becomes a real challenge to find physicians who are well-versed in the management of rare bleeding disorders. And as a consequence, the diagnosis is delayed because of inadequate treatment, and sometimes this also delays access to therapy. And psychosocially, it creates fear, isolation, and stigma, especially in communities where culturally, women are expected to carry on the generation. And if you're diagnosed with a bleeding disorder, it really becomes a big challenge for these women. Since the bleeding symptoms tend to be so variable, I think some of the more common symptoms that we see in these rare bleeding disorders include bleeding into the skin and lining areas, such as the nose, the mouth, and these could be either spontaneous, trauma-related, or during a surgical procedure. Girls and women tend to have heavy menses as well as prolonged bleeding at labor and delivery. Other bleeding symptoms that are reported in these rare bleeding disorders include bleeding into the central nervous system, umbilical cord bleeding, joint and soft tissue bleeding, as well as gastrointestinal bleeding. In specific disorders such as factor 13 deficiency and the fibrinogen group of disorders, spontaneous abortions are very commonly reported. So as you can see, the bleeding symptoms can almost affect each and every organ, although the skin and mucous membranes or lining areas are the most common bleeding sites. Therapy for these rare bleeding disorders has come a very long way. And if you look at the bottom of the slide, you will see that previously in the 1950s and 60s, all these rare bleeding disorders were treated with plasma or FFP and cryoprecipitate. And in the 70s, prothrombin complex concentrates, which contain factors 2, 7, 9, and 10 became available, which slightly improved the management of factor 2, 7, 9, and 10, 2, 7, and 10, I'm sorry, deficiencies. And then there was a big, gap until 2007 when recombinant factor 7A was licensed, initially for hemophilia patients with inhibitors and subsequently for congenital factor 7 deficiency, followed by a plasma-derived single-factor concentrate for fibrinogen deficiencies, for factor 13 deficiencies. And interestingly, for factor 13 deficiencies, you have both the availability of a plasma-derived as well as a recombinant product, depending upon the type of factor 13 deficiency you have inherited. And more recently, in the last decade or so, we have a plasma concentrate available for factor 10 deficiency and yet another plasma concentrate for fibrinogen deficiencies. So if you do have a fibrinogen disorder, I think in 2020, you should really be treated with a plasma concentrate, which is the first choice. And if that's not available, it's cryoprecipitate and fresh frozen plasma. Similarly, for prothrombin deficiency, a prothrombin complex concentrate would be the first choice. For factor 7 deficiency, it's the recombinant factor 7A, the first choice, or a prothrombin complex concentrate with FFP being the last choice. As well as for factor 13 and 10, plasma concentrates are the first choices. Now, the only two rare bleeding disorders where we still have no single factor concentrates available are factor 5 and factor 11 deficiencies. Now, the biggest disadvantage of using plasma is that plasma cannot be virally inactivated, and also the volume that's required to raise factor levels is a lot, and you land up having fluid overload and sometimes severe allergic reactions. So since single factor concentrates are the treatment of choice for most of these rare bleeding disorders, we need to keep a few things in mind when we use these single factor concentrates. Number one is the bleeding history. If an individual has either spontaneous, trauma-related, or surgical bleeding, I think it's important to take that into consideration when preparing for a surgical procedure or a dental procedure. And replacement depends upon what hemostatic level you're aiming for, depending upon the type of procedure, as well as the half-life of the product. Now, since bleeding into the lining areas is a common bleeding site with rare bleeding disorders, and we know that there's an abundance of fibrinolytic enzymes or the clot breakdown enzymes in these areas, antifibrinolytic treatment such as aminocaproic acid and tranexamic acid should be used concurrently with any factor concentrate in order to prevent clot breakdown and prevent future bleeding. Caution needs to be exercised with the use of FFP, with the volume overload issues. And also when you're using the single factor concentrates, rarely arterial and venous blood clots have been reported. So you really have to be careful in terms of the timing of the concentrate, as well as making sure that, if you have a choice, you monitor levels in order to provide a treatment regimen around the time of surgery. Is there a role for prophylaxis with rare bleeding disorders? I think that's something that we don't have great data on. And prophylaxis typically would be related to the severity of spontaneous bleeding that occurs with rare bleeding disorders, as well as bleeding frequency. Primary prophylaxis is usually prophylaxis that's instituted before the occurrence of a bleed. And this is really recommended in an individual with severe factor 13 deficiency because of the very high risk of intracranial hemorrhage. Secondary prophylaxis is implemented after a bleeding event has occurred in order to prevent future joint and muscle bleeds or other life-threatening bleeds. And this can be implemented in an individual with factor 7, 10, 13 fibrinogen, as well as factor 5 deficiencies. Women with rare bleeding disorders tend to have bleeding throughout their lifetime, starting with their menses, during pregnancy, as well as delivery. Heavy menstrual bleeding has been reported in up to 3/4 of all women with rare bleeding disorders. And apart from heavy menses, miscarriages are also reported in a variety of these rare bleeding disorders, as you can see on the slide, as well as postpartum bleeding. The World Federation of Hemophilia report surveyed for heavy menstrual bleeding reported it to be more common with factor 11 and factor 5 deficiency, but can occur typically with any of the rare bleeding disorders. Apart from heavy menstrual bleeding, bleeding at mid-cycle during ovulation has been reported, and sometimes this can lead to rupture of ovarian cysts and causing a condition called hemoperitoneum, where you have bleeding into the lining of the abdomen, causing sometimes life-threatening bleed. Other GYN symptoms that can occur in girls and women with rare bleeding disorders include severe pain during mid-cycle, as well as perimenopausal, sometimes requiring red cell transfusions. Endometriosis, endometrial polyps, as well as fibroids have been reported in girls and women with rare bleeding disorders. And the consequence of all these different complications in a woman actually can lead to severe iron deficiency anemia, causing reduced quality of life, adverse psychosocial consequences, absenteeism from school and work, and sometimes hospitalization and high mortality in the mother. So how do we assess if a girl or a woman has heavy menses? What's heavy to you may not be heavy to me, and this is something that's very relative. We use what's called a pictorial bleeding assessment chart, as shown in this slide, which was initiated in the 1990s. And in today's digital age, this is available as the Sisterhood app, which girls and women can download onto their phones and basically record their menses every month. And as you can see here, depending upon the amount of bleeding, it could be mild, it could be moderate or fully saturated. Points are given for each of these different rates of bleeding, as well as for passing clots. You add up the number of pads on each of these days, which appear like, or tampons, which appear like as shown in this slide, and any score of more than 100 is suggestive of a bleeding disorder. Management includes whether you're considering pregnancy soon, and in that situation, treatment options would include the antifibrinolytic agents, factor concentrate if that's available for a rare bleeding disorder. If pregnancy is not being considered soon, hormonal therapy is the mainstay of therapy in the form of levonorgestrel IUD or combined oral contraceptive pills. If a woman has completed her having children and her reproduction, endometrial ablation and hysterectomy may be other options. So the most effective treatment for heavy menstrual bleeding is a long-acting reversible contraceptive, also known as L.A.R.C, and this is in the form of an intrauterine device. And L.A.R.Cs have been shown to reduce blood loss almost soon after they are placed, up to 80% after 3 months, and almost going down to minimal bleeding after a year. Apart from the levonorgestrel IUDs, a subdermal implant can also be used, but the experience in the bleeding disorder population is sparse with the subdermal implants, and we do have better experience with the levonorgestrel IUDs. Obviously, there are a lot of myths surrounding IUDs, and the American College of Obstetricians and Gynecologists, the American Academy of Pediatrics, the CDC, and the Society of Family Planning do unanimously support the use of these IUDs in adolescents. There may be a small risk of pelvic inflammatory disease in the initial phase, but with long-term use, it actually decreases the risk of inflammatory disease. If an STD is diagnosed, it can be treated without removing the IUD. And most importantly, the risk of infertility is not increased, which is a very common myth. And one of the first questions I get from parents, is my daughter going to be able to have children in the future if she has this IUD? Because, depending upon what IUD you use, they stay in for up to 5 years. And it's reversible, which means that when you do not need the IUD, you decide that you don't want it anymore, it can be removed and fertility can be restored. So now I will hand it over to Dr. Nance.
Thank you. That was a great overview of rare bleeding disorders and how those symptoms can make it so difficult for women to just be comfortably in their bodies, in their normal reproductive function. And because of the heavy menstrual bleeding, because of the need for the hormonal therapy, a lot of times to suppress ovulation and that risk of bleeding from an ovarian hemorrhage, women with bleeding disorders do have oftentimes a more difficult time getting pregnant and managing their bleeding symptoms around that time. So when a couple or a woman with a bleeding disorder is thinking about pregnancy, it's important that we build a team around that couple or that family to help them decide what is the safest way to have a healthy pregnancy and a healthy baby. So most often, having the help of reproductive endocrinologists to help us know, when the woman is going to ovulate, so we can protect her from bleeding symptoms, can be super helpful. The idea behind reproductive endocrinology is really to help a couple achieve a healthy pregnancy and to have both the mother and the fetus be healthy throughout the process. Next slide. Reproductive endocrinology team members typically are, the obstetrician, gynecologist, an obstetrician or reproductive endocrinologist. This is someone who has studied hormones and timing of the hormones and is going to help use hormones to control when a woman ovulates and to help time the best time for fertility treatments. Also important are genetics counselors, so specialists that can help us understand, what the bleeding disorder is and what the risk would be, to the mother as well as to fetus. And of course, monitoring the pregnancy along the way involves, the ultrasound technician, the hematologist, and regular lab testing. One thing that I also put in here is to remind all of us that, health behaviors, including eating a balanced diet and focusing on regular exercise and regular sleep, are very important for the health of us at any stage of our lives, whether we're babies, young adults, thinking about pregnancy, or as we're entering menopause. Next slide, please. So when women come to me and they're thinking about pregnancy and they haven't yet, that's the best time to start. When they're not pregnant but they're thinking about it, it's the best time to start thinking about the preconception counseling. So what does this mean? This is looking at the woman's bleeding symptoms, whether or not she has regular menstrual cycles or if they're irregular. Also, any previous pregnancies that the woman might have had, and any other problems, like whether or not there were hemorrhagic cysts or is there polycystic ovary disease. And so utilizing the personal history as well as the family history. Are there miscarriages in the family? Are there other family members who've had hemorrhage after delivery? And any other genetic conditions that might be known in addition to a bleeding disorder. A physical exam is important for every, for every person along the way. And that generally considers both, from, listening to the heart and the lungs, as well as understanding that the reproductive organs are healthy and normal and what they look like. So that usually involves some type of imaging and then the preconception testing, which is for most women going to look at their blood counts and their hormones and the nutrients, and specifically whether or not they have enough iron. Next slide, please. And talking about iron, and particularly the health of the mother, you know, up to 3/4 of women with a bleeding disorder have heavy menstrual bleeding. And in women with heavy menstrual bleeding, well, if we step back just a little bit, 1 in 4 women without a bleeding disorder, just 1 in 4 women, period, will have iron deficiency and iron deficiency anemia at some point during their lives. Women with bleeding disorders have a much higher chance, meaning that 8 out of 10 or more will experience iron deficiency and iron deficiency anemia at some time during their reproductive life. This means that it's very important as a hematologist that I'm screening every woman who's still having periods every time to make sure that she is not experiencing iron deficiency or iron deficiency anemia. The iron deficiency happens when you're losing more blood than your body is able to take in through your normal food. And iron deficiency can cause a lot of problems from decreased ability to concentrate, restless legs, decreased fertility, decreased breast milk, depression, anxiety, loss of hair, and of course that loss of building intimate relationships. When you don't feel good, you can't possibly perform among your family and taking care of your children. So iron deficiency and anemia need to be corrected before considering a pregnancy. And if pregnancy's already happened, that we're correcting that as soon as we can with IV iron. Some problems that women experience when they're trying to get pregnant are prolonged menstrual cycles, meaning that they're bleeding beyond the time that their body is ready to ovulate. And so they can miss the fertility window because they're still bleeding when they're ovulating, and that can interfere with intimacy. And so having a good treatment plan in place for how to take care of the menstrual bleeding in order to allow normal intimacy and at the right time is very important. Another problem that many women with bleeding disorders have is because that uterus has been bleeding a lot, and because of other problems that can happen from having the bleeding disorder, there can be pain during intimacy. And these are things that can be evaluated and treated in order to allow normal intimacy. And these are very, you know, intimate and private details. However, when you're talking about becoming a mother or starting a family or growing your family, you know, not being able to have that intimate relationship with your partner can really interfere with the health of the individual, the health of the family. So, you know, please bring that up to your provider if you're experiencing that symptom. And then, of course, getting pregnant, being pregnant, comes with a lot of changes to a woman's body. And all of these normal pregnancy things need to be addressed along the way as well. Next slide, please. Once a woman has achieved pregnancy, then of course we need to ensure that she's able to stay pregnant. And for some bleeding disorders, that means that we need to start treatment before the woman starts to try and become pregnant in order to help that early embryo establish itself and then continue to grow. Monitoring the pregnancy is very important, particularly when it comes to preventing or treating bleeding, treating early labor, and of course, managing any bleeding symptoms that might happen during a labor and delivery. Next slide. So we talked a little bit about iron deficiency. Bleeding can be a risk for the mother as well as for the fetus, meaning that the fetus may not be able to tolerate bleeding from the placenta. There's, you know, of course, the risk that the mother has a bleeding disorder, but also the fetus itself may be affected by the bleeding disorder. And so knowing in advance with your genetics counselor what the risk is will help ensure a safe delivery at the time of delivery. And then at delivery, treating and preventing the risk of hemorrhage. And of course, that would depend individually on each person and what the bleeding disorder is to determine what treatment is going to be appropriate. We would want to minimize birth trauma to the fetus if there was a risk that the fetus might be affected, or if we knew for sure the fetus was affected. But also, generally speaking, a vaginal delivery is considered the safest type of delivery for a woman who has a bleeding disorder. And then, of course, these are specific to bleeding risk for a woman, but any other complication of any other normal pregnancy could also happen to a woman with a bleeding disorder. So having physicians who are interested and willing in taking care of patients who have these extra needs during their pregnancy is really important, and that you have people that are skilled and they have support staff around them to help problem solve and to be able to intervene very early at the first sign that something's going wrong. Next slide, please. One thing that's very important is to understand not just what the genetics are for the woman, but also from her partner. Some patients just need management of the bleeding disorder. So treatment of the bleeding symptoms in order to allow a healthy pregnancy. Other families are going to want to do embryo selection. They may want to go through an egg harvest and retrieval, and then testing the embryos before they're put back into the woman's body to see which ones might be affected or not affected by the bleeding disorder. And then there are other options after a pregnancy is established. If that pregnancy just happens and and we're wanting to know whether or not the fetus is affected, then there are several different ways in which we can check for that fetus to see whether or not they're affected. Depending on the risk of bleeding, if there's a risk that the fetus could be affected, then that would help us choose which would be the safest way to check that pregnancy and that fetus for the presence of a bleeding disorder. Next slide. So the process of in vitro fertilization is a multi-step process. A woman has to go through a period of time where she's given hormones artificially to stimulate her ovaries to produce many eggs all at once. So in the typical situation, several eggs start to develop, and then only one or possibly two mature, and those are released each month during normal ovulation. If a person goes through fertility treatments, then their ovaries are stimulated, and then the reproductive endocrinologist will use a very big needle and an ultrasound machine to go in and pull out those eggs. And the risk of bleeding with that procedure is quite high. Therefore, women who are contemplating reproductive endocrinology need to have their hematologist on board and treating them to prevent bleeding at the time of egg harvest. So once the eggs have been retrieved and the woman has been safely treated to prevent bleeding, if that's a concern, then those eggs and the sperm from the father are mixed together, and the embryos are allowed to grow. Then they can be tested. They're generally frozen, and then at a certain stage, and then they can be reintroduced in a very controlled way in order to allow that embryo to then grow in the uterus. I mentioned before, the embryos themselves can be tested, so they can remove one of those cells, do the genetic testing, and then they can tell, which embryos have the condition and which do not. And then the family can, decide what to do with those embryos before they're implanted. Next.
Okay. All right.
Okay. So we could spend a lot more time talking about the reproductive endocrinology, but I think we wanted to spend a little bit of time for questions. And so I'm going to turn it back over to Dr. Acharya.
Yeah, I think we are probably running out of time. So just wanted to stress the importance of women and girls with rare bleeding disorders to be cared for at hemophilia treatment centers. I'm sure, I hope that whoever is in the audience and has a rare bleeding disorder is part of a hemophilia treatment center, which were established since the 1980s from some federal monies. And we've also shown that mortality in these individuals treated at treatment centers is much lower than if you're treated at a regular hematologist's office. Because one of the reasons is that this is a comprehensive care model where you have access not only to the hematologist, both adult and pediatric hematologists. There's a whole team out there taking care of girls and women with bleeding disorders. Several hemophilia treatment centers have specialized clinics now for girls and women with bleeding disorders. So it's really important to take advantage of that. There's genetic counselors and dental professionals, social workers, physical therapists. So you really have a team behind you for all the support that you need when you are planning to undergo a pregnancy. And this sometimes can be a very challenging experience for a woman, and especially for a woman with a bleeding disorder. And treatment centers, are available 24/7. They can help identify your bleeding disorder, make treatment plans, especially for pregnancies. One of the things that really needs to happen is this collaborative effort with the obstetrician and coming up with a very specific treatment plan as to when you would give the clotting factor concentrate, when you would use the antifibrinolytic agent, especially if you have to undergo epidural anesthesia or C-section. I think it's really important to be able to understand all this and specifically ask for a written plan so that everyone's on the same page and you have a safe delivery both for the mother and child. Okay.
Well, that was fantastic information. I know we're getting close to the end of our session, but we did have a few questions that I wanted to pose. One of them was for the for in vitro. Does that is that something that's going to be a high risk procedure for people with bleeding disorders, women with bleeding disorders?
Yes, it is. And that's, the egg retrieval process is not a simple process, and it does involve manipulating a woman's hormones. And so in addition to the bleeding risk, there are also risks just simply from the egg retrieval process itself. And so, that's something that I think each woman's own personal risk needs to be assessed with a hematologist that knows her well and her personal values and her belief system in order to really understand the risk that woman has from the procedure itself. So there's the risk of the bleeding, but there's also the risk of the hormone treatments that is not trivial.
Good point. And then, I think a great way to end this topic would be, we talked a lot about the endocrinology team. We talked about the importance of going to a hemophilia treatment center. For those women who may not have access to an HTC based on where they live, that would actually have a program for women, do you have any suggestions on ways that they could use self-advocacy to ensure that they have a safe and healthy pregnancy?
Yeah, absolutely. Yeah, sorry, go ahead.
I want to let you talk, but I just want to put this one thing out there. Pregnancies happen whether we want them to or not. Sometimes we can try, and we'll never get pregnant. Pregnancy never happens. And then you turn around and all of a sudden you're pregnant, even if you had a great plan. And so, so there are some resources that for physicians, and the Foundation for Women and Girls is a great place that you can, you can pull articles off that center and take them in and give them to your hematologist, where there are experts that can help you find other experts that are close to where you live.
And I would like to add that it also, would be a good idea to try to at least get a consultation with a hemophilia treatment center so that your local hematologist, gynecologist can partner with the treatment center and execute, an appropriate treatment plan. That way, I think it becomes safe for both the mother as well as the child. And that's, important if you have a choice. Of course, in this day and age where there's so many insurance issues and other things that you have to navigate, it becomes challenging, but at least you can attempt to see if that's a possibility. So, all in all, I think it'll benefit everyone.
Wonderful. Well, I want to say thank you so much to both of you, Dr. Acharya and Dr. Nance. That was absolutely fantastic. I learned a ton, and I'm sure the audience did as well. And for those of you who are participating, again, you will receive that evaluation in email, and we would love to hear your feedback on this great session. Thank you so much for attending, and we'll see you at the next session.
Thank you,
Bye,
Brandon.
everyone. Thank you so much.
Bye.
Bye-bye.
Bye-bye.